what I thought was, right, if I was a patient and I walked onto the ward and it was or me, brother, sister, mother, whatever, how would they know that I had a problem, and what would they do within the first 24, 48 hours if I had chronic obstructive pulmonary disease, or diabetes, or I had a hole in my foot that nobody knew about, and actually it's been there for 3 weeks and it stinks, but nobody's actually, I haven't taken my shoes off for 3 weeks anyway, so I wouldn't know that it's now down to the bone or whatever like that. So I thought, how can we start to make it so that we actually do this, literally check, make sure we know what's going on, because quite often, and I don't know why this is as well, but it could take 3-4 days and an awful lot of badgering to get the information from the GP to the inpatient unit about what their physical health history and medications and things like that are. So, and if that's over a bank holiday weekend, it's a real bonus. So, you know, it can take some time, and that's when you find out that there are, insulin and stuff like that. And we do have those scenarios, unfortunately. So, I started working with the diabetic centre at QA. Portsmouth are really good at something. Yay! We're really good. We are top in the country for amputations. We're really good at it. We've got the highest rate. And I don't know if it's whether our surgeons are particularly cautious and they take off a slither at a time and that counts as an amputation, or whether, other areas go, well, we've got a really low rate because we just take it off at the hip straight away. We don't bother going up the leg, we just take it up the hip. So we've got quite a high rate. So it was one of those things that came up and I thought, wow, perhaps we could, maybe not be so good at that. So I started to work with the diabetic centre at QA. And I'm developing a pathway. For me, it's just a sensible guide to somebody coming through the door and literally us looking at whether there's signs and symptoms of diabetes. If there is, what are we doing? Please take their shoes off. Please, if you notice any, unusual sores, scars, if they don't know what their treatment is, how are we going to do that? I've kind of done a pro forma called diabetic bingo, which includes, some people don't like it, but they're prudes. It includes about sex, can men get erections? Because that's really important. If men can't get erections, then that contributes to, obviously in their terms of their outcomes and their control of their diabetes. So that's on the diabetic bingo list, and I don't know that many men have ringed it so far, but we're getting there. Getting the paperwork onto the ward and getting people to use it, as you were saying, it's all about making those changes. So that's some of the diabetes stuff, and I'm also going to be working with the Diabetic Centre to actually accredit our pathway so that they come down and they actually look at how we care for our diabetic patients, and they kind of give us a bit of a Brucey bonus gold star, because they're starting to do that with primary care. They're doing it with certain doctor surgeries that do seem to manage their diabetic patients particularly well, and I thought, well, that would be quite nice if we could do that on the inpatient units and start to make sure that we're doing it exactly the same as primary care, and then we start to, even talk to them to them, that would be great. So then that led me on to working with podiatry. So we have a podiatrist who comes and teaches our diabetic link nurses. We've got a small group of those. And I've just developed a little intranet site where I upload anything that I think is going to be of use. So that would be things like care plan templates, that will be slides. We've got the podiatrist, a guy called Matthew King, he's great. He's really interested in educating people about simple foot care. So we've got all the diabetic slides that they work with Diabetes UK on there as well. So we're working with those, and we're sharing that information amongst older person's mental health and learning disability, and frankly anybody who wants to know about it. The more the merrier. Let's join in and get as much information shared as we can. We did a diabetic. What also I do is I'll try and do sort of every 3 to 4 months a day or an afternoon where we get people in who kind of a bit like this, but we'll be on a certain subject that is relevant to mental health. So diabetes, heart disease, COPD. The next one's COPD, because I thought we'd do it for kind of winter theme, tying in with sort of like, just the whole COPD and the winter cough and the difference between that and asthma. So hopefully get somebody from the British Thoracic Society, and I've got somebody else coming from somewhere else and some physios. And it would just be anybody. It'd be, the diabetic day we had service users, we had staff, we had, in fact the best contribution came from one lady who's one of our regular patients who's diabetic, who was just kept asking those questions. She was great. She really did sort of turn people's heads inside out. That was great. We had people obviously from the diabetic centre, and we had just interesting stuff going on. So we're going to do one like that with COPD in the autumn. We're linking in with sexual health and the under 25 project because they want to do some research with us as well about the chlamydia and under 25. And I'm linking in with public health because I got a little bit of a thing about, there's lots and lots of work in mental health about eating disorders and anorexia, but there's not much about obesity, and we have quite a large group of people who are overweight, who have got metabolic disorder, who smoke, who are going to die younger because of their mental health problems. You live in Portsmouth, you go to the statistics, what we call our JSNA, you live in certain areas of Portsmouth, you die on average 11 years younger anyway. So combined with mental health problem, you know, you're not going to live very long anyway. So I'm working with public health to, when I say I'm working with them, what I'm not sort of like, it's not like the poster sort of stuff. It is really saying, not running or anything, but it was a discussion about why health trainers couldn't work with people with mental health problems, and it came up that old thing about risk, you know, risk and people working with people who, you know, may have had a history of sort of violence or aggression in the past. So, but we are going to be doing more work with them, and we're revamping the education pathways because I don't think a lot of it fits what we're doing. We're all moving forward, but we're not actually, the learning and development isn't actually sort of bespoke and catching up with the different type of more acute clients that we're dealing with, and they've got more physical health problems, and we're not actually addressing that. It needs to sort of tie in and work in tandem with them. I look at each patient and I go through their file and I look at their history, I look at their physical health history once a month, and obviously, unfortunately, some patients are there, you know, a month after a month after a month, but I look to see if they've got a physical health problem, and then I look to see what it is, how it's care planned for, and I look specifically to see if they've had a health assessment within 1 year, what the condition is, whether there's a care plan for it, and what the patient's understanding of their condition is as well, because quite often there is no demonstration of what they understand about it. So I do that, and it looks a bit like this. So I send this back to the ward, and that'll be the patient's name, then it'll be whatever their problem is, and where it says blue is desirable and red is essential. So, you know, if I'm reporting back on people with diabetes and COPD and stuff like that, they have to have care plans, or epilepsy or something like that. And sometimes they're not quite there. But the ward staff, where I'm working with them clinically, and I'm setting up a sort of intranet site which has got lots and lots of information on it, and I liaise with them directly and say, if you're not happy, if you don't feel comfortable doing this care plan, then we'll do it together. And so we're starting to get better quality care plans out there. The next thing really is for us to start using a physical health tool questionnaire in the admission pack. One of our next steps is to look at the inpatient bit. So Sarah does her bit, and then